Doctors are supposed to give hope to the patient and treat the disease for which the patients come to us. However, in this video, I will show you the different aspect of this same phenomena. Now, we had a patient who came to us. She had a bilateral diminution of vision, and in the right eye, she was recently operated for her visually significant cataract, and the surgery was eventful so that she didn't gain very good vision out of it, and later she developed retinal detachment in that eye, and the other eye was having significant cataract. Now this patient came to us with a hope that we will correct the right eye which was operated for cataract and had a detachment. But looking at the condition of the eye, which showed us a pseudophakic eye with a retinal detachment, which was too bad to operate, and the vision was a defective PR. Now, in this scenario, as a retinal surgeon, I know that there is hardly anything which we can deliver. Although this eye can be operated upon, but it is also obvious that these eyes do not gain much vision even in spite of good retinal detachment surgery. In such scenarios, I tell the patient that this is the practical issue of gaining vision after retinal detachment, which is not very good, and in given scenario she will still have to depend on her left eye for her daily needs and visual performance. And I counseled her that investing time, money, and bodily pain in the right eye is not going to be fruitful. So I counseled her to get operated for the left eye, which had a simpler solution, just removal of the cataract and implantation of an appropriate IOL, and she would gain good vision out of it. And the patient finally agreed to my counseling, and we went ahead and operated her. This is the surgery for the same patient. The patient was very apprehensive, as we can expect that a patient who had lost vision after cataract surgery would be very much worried about happening the same to this eye. So I had planned a clear corneal phacoemulsification, keeping the incision at steep axis. So depending on the incision site, I had to use my non-dominant hand to operate the patient, and the surgery was very routine. Being a young lady, she didn't have much of nuclear sclerosis, so I was anticipating a soft cataract. So proceeding for capsulorhexis after injecting intracameral lignocaine followed by intracameral viscoelastic 2% methyl cellulose gel. This video is being run at 1.5 the actual speed, just to hasten the visuals so that the interest of the audience is retained, and at the same time none of the steps are missed. A nicely sized regular capsulorhexis has been performed. Although a side port may not be needed for such a soft cataract, but I made it because I didn't want to take any chance, because I was also under little pressure to perform well for this patient who was trusting me for operating this eye after undergoing a poor vision surgery in the other eye which was operated elsewhere. I also feel indebted to these patients who trust me in these scenarios, and that is a great honor for me regarding their faith in me that I'll be able to restore their eye and give them useful vision. So it is a soft cataract. The nucleus has been removed, and now the epinucleus and remaining cortex is being aspirated using the phaco tip. There's just some amount of residual cortex which will be aspirated using irrigation aspiration cannula. The best and safe way to aspirate the cortex is to engage it at the rhexis border so that the posterior limit of the lens fiber is automatically peeled off from the posterior capsule, and one doesn't have to reach up to the posterior capsule, which may be a little unsafe when using phacoemulsification. Implanting a single piece monofocal hydrophobic IOL. This goes into the bag, the leading haptic as well as the trailing haptic. Just ascertaining that the IOL is in position, both the haptics in the bag, and proceeding for removal of viscoelastic using irrigation aspiration cannula. Though I expected this tunnel to seal well, but I just didn't want to take any chance, so hydrated the main incision so as to confirming the sealability of the wound and maintenance of the anterior chamber. Post-op day 1 picture which shows us a very clear cornea, centered IOL, and the vision was excellent, 6.9 unaided and 6.6 with pinhole. Thank you.